Good day, everyone. First of all, I would like to thank Professor Canecki-Varžić and Professor Mirošević for inviting me to participate in this excellent meeting with excellent expert. Also, I would like to thank for introduce my dear young colleague, Dr. Strinović. We work together in Clinical Hospital Center, Sister of Mercy in Zagreb. Our hospital has a long tradition of treatment with multidisciplinary approach. The first meeting of multidisciplinary approach was since back in 1981. It was organized by Professor Mladen Sekso for the patient with the pituitary tumors. Until then, from then until today, meetings are regularly held, not only for the patient with the pituitary tumors, also for the patient with the other endocrine tumors. Today, we will hear something more about multidisciplinary approach to neuroendocrine tumors, and Mateja Strinović, my dear colleague, will tell you something about our MDT teams. Thank you.
Thank you for the introduction. So my name is Mateja Strinović Morić. I am endocrinology specialist at the Department of Endocrinology in Clinical Hospital Center Sisters of Mercy. And I will say something about the multidisciplinary approach to NETs treatment in Croatia. So multidisciplinary team care is widely recognized as a part of best practice management, and it is recommended by many guidelines. Experts together decide about what is the best for each patient. Also, multidisciplinary team care is associated with improved survival, timeliness of treatment, and adherence to guidelines. It improves decision making necessary for patient care. Multidisciplinary approach is important in management of neuroendocrine tumors because these tumors are rare malignant neoplasms, but incidence of these tumors is increased for the last few decades. Also, they originate from neuroendocrine cells, which are located in any organ in the body, but mostly these tumors occur in gastrointestinal tract, lung, and pancreas. The classification is based on the primary site of the tumor, proliferation, index, and differentiation. Also, these tumors can be functional and non-functional, can be sporadically tumors or part of inherited disorders. So, management of NENS is very challenging. Here is a classification of neuroendocrine neoplasms of the World Health Organization. So we already heard about this from Professor Ticinović. So a classification is based on primary site of the tumors, grade and differentiation. Grade is the aggressiveness of the tumor, and differentiation means how similar are tumor cells to their non-neoplastic counterparts in the same tissue. We have 3 grades of the tumor: low, intermediate, and high, and neuroendocrine carcinomas. According to differentiation, these tumors can be well differentiated, and neuroendocrine carcinomas are poorly differentiated with poor prognosis. Also, there is a group of mixed neuroendocrine and non-neuroendocrine neoplasms, but these tumors are very rare and also have poor prognosis. We also see this slide, but this is a treatment option for neuroendocrine tumors and development of that through the history. We can see that for the last 12 years, there was a significant improvement of the therapy options for neuroendocrine neoplasms. This is the classification and the treatment options for NENS. These treatments is based on the primary sites of the tumors, also according to grade and differentiation. So we heard that among these therapy options are somatostatin analogs, then molecular targeted agents, chemotherapy, PRRT, and immunotherapy. This is another slide with treatment options for gastroenteropancreatic NETs. And according to this all, we can say that management of neuroendocrine tumors is very challenging, and it's difficult sometimes. This is a study that investigated clinical outcome of patients with NENS managed by a multidisciplinary team. And in this chart, we can see results of this study. After first multidisciplinary discussion, there were changes in the medical treatment. For example, we can see that targeted therapies were introduced in 1.5% before the multidisciplinary discussion, but after the discussion, this number was increased. Also, for systemic chemotherapy, 30% of patients was going to chemotherapy, but after the discussion, only 6 patients. So also additional radiological and nuclear medicine procedures were requested in 83 patients after the first multidisciplinary discussion. Disease staging and grading was modified in 30 and 17% of patients. And the change in therapeutic management was proposed in 50% of patients. Multidisciplinary management in our hospital started in 1981 with the MDT for pituitary diseases, and was founded by our endocrinologist, Professor Mladen Sekso, who was a fellow of the Croatian Academy of Sciences and Arts. Over 3,000 patients with pituitary tumors were treated in our hospital, and the first transsphenoid surgery in Croatia was performed in our hospital. Since then, over 1,000 patients with pituitary tumors underwent endoscopic surgery. We have MDT for pituitary tumors that is held once a week in our department, and the members of the team are endocrinologists, neurosurgeon, pathologist, and radiologist. Also, we have MDT for neuroendocrine tumors that started in 2016 at our department, and the team members are endocrinologist, surgeon, pathologist, radiologist, oncologist, nuclear medicine specialist, and gastroenterologist. We present patients with NENS from all over Croatia. These patients are mostly with metastatic diseases, but also they have localized tumors, mostly pancreatic NETs. And also we have patients that have NETs as part of the inherited disorders like MEN1 and MEN2. This is a patient with the Zollinger-Ellison syndrome that we discuss at our team. It is a young patient, female patient, 41 years old. She was admitted at our hospital because of the severe gastroenterocolitis. She was at very poor condition. She was cachectic. She had carpopedal spasms due to hypocalcemia. She had severe metabolic alkalosis, and she almost died because of that. So after we stabilized her, we did diagnostic workup, and on the gastroscopy there were lots of ulcers in the esophagus, stomach, also in the stomach. And we did colonoscopy. There were multiple ulceration also. So the levels of gastrin and chromogranin A were very high in these patients. And we diagnosed this syndrome. Of course, we did MSCT of the thorax and abdomen. And on that CT, we revealed multiple tumors in the pancreas and in the duodenum. We did endoscopic ultrasound with biopsy from 1 or 2 tumors. These were small tumors, smaller than 1 centimeter. And the PhD was a neuroendocrine tumor. So we needed to decide what next with that patient. We sent her to do PET-CT with gallium dotatate in other institution because this imaging method is not available in our clinical hospital center. And on that imaging, Well, we can see that these tumors have somatostatin receptors. Expression is good in the tumors. So we needed to decide which therapy to give a patient, what to do with the patient. She was taking proton pump inhibitors, which is the mandatory in this syndrome, but also we needed to decide whether to send patient to surgery or to treat her with therapy. And we decided to treat a patient with somatostatin analogs because surgery will be radical surgery, pancreatic duodenectomy, and that operation shortened life of this patient, and the quality of life is impaired after the operation. So we decided to give her somatostatin analog octreotide. And in men 1 patients who have small tumors, they have very good prognosis. Its probability of tumor spread is low. So here is another patient that we discussed at our multidisciplinary team. It's a patient with metastatic atypical lung NET. He operated lung tumor 8 years before we reveal in the liver metastasis. So he was treated with somatostatin analogs since 2019, and his disease was stable. We can see on the SPECT low dose CT that liver metastases have good expression of somatostatin receptors. That's why he was on this therapy. But his disease was stable until this year, where CT revealed progression of the disease in the liver. So we sent him to do PET-CT with gallium dotatate and to see if there is still somatostatin expression in these lesions. And there were good expression in the metastasis. So we discussed him at our multidisciplinary team and decided to send him to PRRT treatment abroad, because we don't have that treatment in our country in this moment. Patient finished 5th cycle and out of 6, and he's feeling okay now. By now, disease is stable. And on the conclusion, I can say the multidisciplinary approach is widely advised for an effective care of patients with neuroendocrine neoplasms. Multidisciplinary care is strongly encouraged by the European Society and American Neuroendocrine Society. These patients have better survival if they are managed by a multidisciplinary team, and important is patient-centered approach for the optimal care of these patients. And this is the picture of our team. Thank you very much for your attention.